Zollinger Ellison syndrome, also known as gastrinoma, with a classical feature of abdominal pain. We can see classical features are like abdominal pain, peptic ulcer disease, diarrhea, weight loss, steatorrhea, reflex esophagitis. Due to increased production of gastrin, we can see some trophic effects like on parietal cells and enterochromaffin cells, which causes prominent gastric folds. It's mostly seen in fundus. So we can see gastric folds, prominent gastric folds in fundus in Zollinger Ellison syndrome. In 20 to 30% of Zollinger Ellison syndrome, it is associated with Men-1 syndrome, and for that we have to rule out hyperparathyroidism by measuring ionized calcium prolactin level. So on investigation we see for serum gastrin level. Here, if the serum gastrin level is more than 1000 picogram per ml, we diagnose it as gastrinoma. But in some cases, like chronic PPI ingestion, H. pylori infection, and renal failure case, we see some marginal elevation of serum gastrin level. So, to rule out that, we have to do an test, that is secretin stimulation test. If after 15 to 20 minutes, if we see serum gastrin level is more than 200 picogram, in 15 to 20 minutes there is increase in serum gastrin level, that is more than 200 picogram per ml, then it is seen in Zollinger Ellison syndrome. So now the gastrinoma is mostly seen in gastrinoma triangle, that is Passerose triangle. So if it is not in Passerose triangle, then most common site is T1, that is first part of duodenum. So what is Passerose triangle? Passerose triangle is the junction of cystic duct and CVD, neck and body of pancreas, and second and third part of duodenum. So it is the junction of cystic duct and CVD, the neck and body of pancreas, and the junction of second and third part of duodenum. The triangle which it makes is a Passerose triangle, and here it is the gastrinoma occurs, and which is seen in Zollinger Ellison syndrome. So how we will localize? For localization we do CT and MRI. But if the tumor is less than 1 centimeter, then we might not be able to see the tumor. So for that we have to do somatostatin receptor scintigraphy or endoscopic ultrasound, and if we do not see, then we have to do surgical exploration. So for the treatment of Zollinger Ellison syndrome, that is gastrinoma, resection is the treatment of choice. So if the tumor is in head of the pancreas, then we do Whipple's, and if it is in tail of the pancreas, then we do distal pancreatectomy with splenectomy. So here minimum 10 node resection is to be done. For adjuvant therapy, we do streptozocin, doxorubicin, and temozolomide. And for METs, we do radiofrequency ablation and cryoablation. And for palliative surgery, if it is non-operative, for palliative surgery, we do gastrectomy, total gastrectomy.